actually the Biggie Smalls, Junior Mafia, Get Money. They sampled it from somebody, I forget who, but it's good. Oh, my kid built this Lego set there, the 2 ships.
Oh, wow.
He built those.
Yeah, next swing.
Yeah.
TIE fighter.
Yeah, he's good, dude. He's good. So, all right, cool. We got Dr. Angel Rigueras and University Ortho.
Yes.
Amazing pain management doctor.
Thank you.
You reduce pain, eliminate.
That's the goal. Eliminate as much as possible.
Yeah. And we just got here. You did a whole day in the OR.
Yeah.
Last case you told me was a spinal cord stimulator.
Right, a permanent implantation of the spinal cord stimulator.
A permanent, so they do the temporary first.
Exactly.
Try it out, trial period.
Yeah, exactly, to see if this is something that we could permanently put in.
Cool.
If it's going to work for the patient.
Cool.
So, yeah.
Cool. So tell us a little bit about you.
Okay. So
where are you from?
Well, originally from Miami. My parents Cuban and Spanish.
Yeah, ya tú sabes, dale.
Hialeah.
Nice.
Spent some time in Malaga as a kid growing up.
Oh, wow.
And then here, went to school local, Nova Southeastern University. And then from there, went up to Michigan State University for internship, residency, fellowship.
Coldest place ever compared to Miami.
I can tell you stories. I mean, talk about an opposite climate. Negative 47 degrees for 3 days in the Upper Peninsula of Michigan.
Ugh.
Yeah, that was an interesting experience coming from Hialeah.
Oh, in the Upper Peninsula.
Upper in Marquette.
Wow.
Yeah.
So all the Michiganders are like, tell me where you're at.
It's exactly, you know them.
Yeah.
They're always like, the moment someone does this, you know they're from Michigan.
Super nice people.
Oh,
super nice
awesome.
people. Except for my ex. She was a bitch.
Oh, was? Oh, well. What part of Michigan?
They all say they're from Detroit, but it's really the burbs. But she was actually a nice person. I'm just being a jerk.
Smooth
just in case my wife is watching.
So I did my internship and residency in physical medicine and rehabilitation, which is known as physiatry. And then I did my fellowship in interventional physiatry.
Okay.
And had an amazing experience. Not a lot of people would say that a lot of times about Michigan, because of the weather, but really had an amazing career experience there.
Cool.
And then, I decided to come back down because of family reasons.
Okay. You came down to Florida.
Yeah, I came back to Miami.
And you were a professor up there in Michigan.
Yeah. So through Michigan State University's College of Osteopathic Medicine and College of Human Medicine. So part of their Department of Orthopedics and Physiatry.
Okay.
And so all the residents that would come through there, plus orthopedic residents, we had a neurology residents, and then part of the fellowship training for interventional physiatry through Michigan State McLaren Hospital in Flint.
Okay. So, Flint, I've been there.
Yeah, and
don't drink the water.
No, I lived there when that was happening.
Wow.
I was living right in the middle of Flint.
Did you have the water situation as well?
I did.
Wow.
I did. I lived in an area named Mott Park, which is really close to the main hospital called McLaren Hospital. And so my water started coming out yellow and had a weird, funny smell and taste to it. And we tested it, heavy lead. And
Wow. Yeah. That's crazy. I know there's a lot of litigation about it, but it causes birth defects, brain defects in young children.
Yep.
And people are bathing in it.
Oh, they're bathing. They were bathing in it, cooking in it, drinking it.
Yeah. It's crazy.
It was a tough situation. Yeah. It's a great town. Those people, I mean, you want to see what hard working is. You go to Flint, Michigan, you meet someone from there.
Yeah.
But unfortunately, they just can't catch a break. So. Yeah.
Michigan people are great. It's just my ex.
Yeah, she's the one exception you found. Good job.
Actually, she had a really nice family. But anyways, so Michigan, great people.
Yes.
Great professors.
Yes.
It's funny. I was talking to this guy. He's a trauma surgeon here. I got to introduce you to him. He's hilarious. I meet him for lunch and he's talking to the resident and he's telling him, all right, listen, you're going to get the guy, you're going to get the tube, you're going to put this thing through the tube, and then the guy's going to breathe again. And I'm just sitting, I'm like, what is going on with this right now? I don't think all residents are that good, right? Like,
no. Yeah. No. I mean, you gauge which residents you can be like that with, right? Like, as you get to know them, I had residents who, to be honest with you, in their fourth year, I was like, I think you should repeat residency.
Yeah.
And other guys in their second year, they're basically ready to become your partners.
Wow.
Yeah. So it's a crazy experience. I also spent time teaching the nurse practitioners at University of Michigan. So talk about being part of that huge rivalry.
Yeah.
And we would have them, both schools coming through the clinic. So it was
cool.
Yeah.
Any fights break out?
Almost. Some of those football fans, that's like religion up there.
Yeah.
That's like soccer in, Central South America. Well, Michigan, those two schools, that's a rivalry.
That's like FIU, UM. They had a big fight on the field a few years ago.
Oh, I didn't know that.
Massive fight. Yeah, a lot of players got kicked out and in trouble, but yeah.
Wow.
Yeah, and that's FIU and UM. I mean, go Panthers. So cool. So you're down here in Florida.
Yeah.
You're with a great orthopedic group, University Ortho.
Yes.
You do facet injections,
right,
epidurals, rhizotomies,
SI joint injections.
SI joint.
I do the peripheral nerve blocks, intra-articular injections. I'm actually also a headache specialist. So a lot of these people which is very common, and a lot of acceleration, deceleration type accidents end up with all sorts of cervicogenic, meaning neck oriented or occipital neuralgias. So I treat them. A whole host, and then the more advanced cases, like what we talked about, spinal cord stimulators and kyphoplasties, which is where you actually fix a fracture in the spine. There's quite a bit of different things we can do.
I tell the clients, they put cement in your spine.
It's funny you said that. I had someone come and tell me that, they told me it's cement. Can I just bring my own cement? And in his mind, yes. An old Cuban guy, God love him. He was like, well, how much money is this going to save me? Because I know medical stuff is expensive. I'm like, you can't go to Home Depot and buy this.
Yeah.
And in his mind, well, why not? It's cement.
Yeah.
He was ready to just have cement injected.
Wow.
Yeah.
Interesting. That's like, that's Miami for you. They do the fix-a-flat Brazilian butt lifts.
Right. I mean, unfortunately, there's been
pretty dangerous.
Yeah.
So, you mentioned headaches.
Yeah.
I get a lot of clients, I'm a personal injury lawyer. I get a lot of clients who complain about constant headaches after an accident. Yeah. And they literally go crazy over time. You can see them mentally kind of break down.
It's anguish.
Yeah.
Headaches are, it's interesting when you look at headaches. And again, pain in general just wears you down because there's not much escape from it. And this is what a lot of people don't understand. When you suffer an injury, right, an accident, it's not just, here's an MRI, here's a disc, and off you go. There's a lot more to it than that. There's all sorts of soft tissue injuries that can occur. And a common one, like you mentioned, is headaches, specifically headaches that come from the spine. So we refer to those as cervicogenic headaches, meaning they originate from the neck.
Where do they feel those? Just so our viewers could see, like, are they feeling it here, or are they feeling in the base of the skull kind of thing?
So both. So there's over 200 different type of headaches. Most people only think there's a few.
Is one of them called wives?
Sometimes, but I can say that I'm divorced now. And mother-in-law.
I'm still married. I don't get in trouble, but she knows.
Yeah, no, not wives. No. So there's a whole host of traumatic headaches, and some of them, like the ones that come from the neck, very commonly back here. And these headaches can move forward to the top, give you pressure on top of the head. A lot of times they can come around only on one side and wrap and catch your eyes. And they always say, I have a migraine. And in truth, in the office, we do a simple little block, and within minutes, it's like complete night and day for them.
Where do you do this? Like, where you inject them with a block?
So if it's the most common one that I find is something called occipital neuralgia, which is a nerve that starts at the back of your skull and wraps around like this. There's actually two of them, the greater and lesser. So anyways, as it wraps around, it causes this sometimes pressure, squeezing, numbness, and tingling. And it can come around this way to the eye as well. So I put medicine, I literally block it right there. And within 3-4 minutes, the headache is almost completely gone.
Do you put Botox or like a
You can put Botox. Botox is considered more at the end of treatment. If everything else has failed, Botox is the treatment, and there's actually 31 spots that you have to inject for that headache protocol. This one in particular, I use a little bit of numbing medicine and a little bit of steroid. And for my diabetic patients, I avoid steroids because it can really shoot up their sugar. So I use an anti-inflammatory called Ketorolac or Toradol. That's usually something when you go to the ER, they'll give you. And when I do that, you can see their eyes are droopy, their scleras, the eyes all red, and they can't tolerate light. You do it within minutes. Their eyes are cleared up. They'll tell you, "Oh my God, it's so much clearer." And it's one of those aha moments for them.
Okay.
And at that point, we know that I've proven what the cause is, right?
Okay.
So, and that's actually the goal of what I do. The first thing I do is I help diagnose the problem. And I mentioned, you can do an MRI, and that's helpful, very helpful, but that doesn't give you all the answers. Mm-hmm. So if I think it's this occipital neuralgia and I put medicine over that nerve and the nerve blocks, I block the nerve, and the pain, over 50% reduction of pain immediately. Mm-hmm. That's how you confirm that diagnosis. Now I know. I can tell the patient, hey, this is the type of headache you have. It's called occipital neuralgia. If the pain comes back, then we have a whole host of different options. I can either go down further, deeper to the source of that nerve, which is a joint in the cervical spine called the C2-3 facet joint. Okay. And these are basically where the back of the spine, where the vertebra come together and meet. It's a joint. And at that level of C2-3, that nerve wraps around, and that's kind of where it originates. And I can put medicine there.
So are you saying that it's not, the injection is not permanent?
No.
Oh,
it can be. I've done this to many people, and a year later, they're still good. Mm-hmm. Usually what we see and what the literature kind of tells us is about an appropriately performed occipital nerve block. And you can actually extrapolate this to a lot of the other type of diagnostic, and that's the key word, diagnostic procedures, which is typically the first injection you get.
Oh my God, I got to tell you about diagnostic. So I'm a personal injury lawyer. I'm young. I'm a baby. I get this doctor. He's a chiropractor who owns a pain management group. And he says, yeah, the pain management doctor wants a diagnostic injections, diagnostic facet injections. And I'm like, okay. And he goes, yeah, my guy doesn't do them. And then I'm like, okay, so you're a pain management doctor, you don't do them. I got it. So I'm calling around, asking around. Within 15 minutes, I realized this guy's an absolute moron because they are diagnostic and therapeutic. It's diagnostic to see if there's an issue, right? And if it benefits the patient as well,
it's
great.
Therapeutic.
Yeah.
So, and unfortunately, if you hear that, my advice is go somewhere else.
Oh yeah, I stopped working with that guy. I was like, dude, I cannot. No. This is bizarre.
And when you talk about pain management, it's such a new field, right? Mm-hmm. The concept, especially here in Florida, the concept was, let me have a Vicodin, let me have a Percocet, and that's pain management, right? I'm just going to get pain medications. Mm-hmm. And unfortunately, that caused a lot of problems. And that's not what it's like going to the ER thinking, ER medicine, that means I'm going to get intubated. Right now, right, okay. It's not life-threatening. There's a whole host of things. So in my specialty, it's a whole thing. It's a whole spectrum of treatment and workups, like the diagnostics. So, if I put medicine in those joints or over that nerve, mm-hmm. and the pain doesn't come back, well, it was therapeutic. Mm-hmm. Great. There's nothing more to do except let's strengthen the area so we can make sure it doesn't come back. We stabilize the area. If it comes back, at least now I know where the problem is, mm-hmm. and I can say, okay, what's the next step? Right. Mm-hmm. So maybe I did that and the headache snapped back, but now they're like, oh, you know what? My pain in the neck is just right here. Great. I don't have to worry about that nerve anymore. Let's worry about the joint or vice versa or whatever it is. All of a sudden they may say, yeah, my headache and neck pain are gone, but my arm now is killing me. Mm-hmm. Oh, well, maybe that herniated disc that you weren't complaining about before has been unmasked.
Right. You reduce one pain, you eliminate one pain or reduce that pain, and they're starting to realize there's more pain in other body parts. Right.
And it's crazy. Your brain really only pays attention to one pain at a time. It's called gate, like a gate theory. Okay. And it's crazy how we discovered this. But anyways, so what happens is if I was to saw your arm and leg off at the same time, something horrible, right? It's the morbid doctor humor. You wouldn't be able to say ow to your leg and arm at the same time. It's like ow, 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 ow. Okay. And so as you reduce one pain, you unmask the next pain. It doesn't mean it's less intense. It just means for whatever reason, your brain was only paying attention to this one thing. Mm-hmm. Yeah, we kind of discovered this actually during Nazi Germany. They were doing these crazy, horrid experiments during people. There was the doctor. I can't remember his name, but there was a doctor. Actually, I know you're talking about. He went part of the Charles. They call him. They called him Dr. Death. I'm trying to remember his name. Yeah. Anyways, so we found some of their studies, and then it was a horrible, unfortunate way to discover that.
Yeah.
So based upon that, if I examine you, I look at your MRIs, and I'm like, the driving complaint is headache, and I treat that, and I diagnose it, and then possibly treat it. But in doing that, something else may come to the surface, and then we explore that. We help diagnose its causes, and then that's how you really do it.
Yeah.
And so a lot of guys who at the beginning of the specialty were never really trained in neuromusculoskeletal medicine. They were either ER docs or family practice guys, or just guys who really didn't have a specialty, and said, I can do really good here. I can make a lot of money giving out Percocet. Yeah. And that's what they did. And unfortunately, Florida was really bad for that. And some of those guys are still around, and they figured out if I stick a needle in someone, I can say I'm an interventionalist. Yeah.
Well, it's funny you mentioned that. I was looking up, one of the things I do is I represent doctors for lawsuits, and I'm researching some of the lawsuits. And there was a case out of Orlando area, non-doctor owner, and he's telling the doctor how to treat the patients, when to order the MRIs, and in particular, give this guy an injection. And the doctor goes, but he's got diabetes, and he's got a very high blood sugar level. And he goes, I don't care, just do it. And the doctor walked away. Because of the risk to the patient and all that. So
good for him.
But a lot of people sometimes, fall under that.
Well, it's I hate to say this, but a lot of you think about who becomes a doctor, right? Mm-hmm. These weren't these very business savvy, very cutthroat, very gun. I mean, these were, if any doctors are listening, sorry, but it's the truth. These were the nerds in high school, right? And then when they get to college, they concentrated their nerdiness, and then they get to med school, it's like nerdum haven, and it just continually perpetuates like that. So a lot of times, a lot of doctors, they don't know how to stand up to that bullying, right? They don't, right? Yeah. Lawyers can intimidate them, businessmen can intimidate them.
Crazy ass lawyers, man.
Tell me about it.
I hear the horror stories, yeah.
But doctors feel that way a lot of times, and unless they have a lot of experience understanding how things work and understanding their role, which is, hey, you really are the expert. Like, you're the person who truly understands this at a level that most people can't even comprehend. Right. It's like a lawyer understanding law, right? But a lot of times they don't have the personality types to really be able to stand up for themselves, and they get themselves into some trouble because
it happens. Yeah, unfortunately. And you mentioned the pills. That's when I talk to my clients and I try to educate them about, okay, there's therapies you could do. This is what an MRI is. This is other tools in the box to help reduce your pain, injections, other types of surgeries. And then they're like, I don't want to do pain management. I don't want to be addicted to pills. And I feel like there's this misconception now from the media, and maybe 20 years ago, maybe it was around that time, 20 years ago, where everybody's just handing out pills. And I think a lot of that in Florida, especially, I think they dealt with it pretty good in the last 10 years. I feel like those are gone, right? Yeah. For the most part. Are you seeing that too?
I got to tell you, you hit it right on the nail. And when you said the media, unfortunately, when it comes to medicine, all doctors are scientists, right? And we're taught how to think critically, how to be data driven. And unfortunately, when you have non-data driven decisions occurring, it really screws up medicine. And pain medicine, pain management, pain medicine was a prime example. I can't tell you how many patients I had in Michigan that I kept working full-time with overtime. And if you looked at their MRIs, you looked at their x-rays, you looked at what they were experiencing, I mean, these people were jacked up. Like every muscle in the shoulder, rotator cuff tear, multiple fractures from the spine that have been old. I mean, just horrible arthritis because they work 75 hours in a factory every week. They get really banged up. And what kept them functional, engaged in their work, engaged with their families, was actually pain management, pain medicine. But it's not like, you hurt, here's a Percocet. No, there's very specific guidelines on how to do this. There's very correct ways to do it. And unfortunately, some people doing, diverting their drugs, or drug dealers doing all this stuff, the media got a hold of that. And they turned it as this, we have this crisis. And I'm not saying people don't abuse this stuff. Right. Well, instead of differentiating abuse, people who are doing illegal and abusive stuff with this versus the patient who really needs it. They just generally categorized everyone. And they went on a news media spurt and basically villainized these type of medications and shamed people who need them.
Right.
And I have a sad story where I had a patient, a young guy who got pinned between two cars. He was a paraplegic, horrible pain. And he wanted to keep working. And, we had him on just a fentanyl patch, 25 micrograms and tramadol. It's, and he was continuing to work. And so his fiance, if I remember this correctly, heard all this media news and she started shaming him for using this.
Oh, wow.
So he stopped. And long story short, the pain got so bad, and unfortunately he kind of discharged himself from my practice. The pain got so bad, rather than calling me, he just decided to commit suicide.
Wow. Because
he'd rather that than be shamed.
Right.
And this is a guy, it was horrible. And I got news of it from his mom. And no one takes ownership. None of the media people, none of the people who propagated this. So what I always explain to patients, back to your point, is, look, these medications do have a propensity to be abused, but addiction is really a psychiatric problem, and it's a genetic issue, and there's not like, if you take a Percocet, oh my God, I'm going to become addicted. No different than if you take a sip of alcohol, you're not going to become an alcoholic, right? This isn't heroin or, crack. So ultimately, I explained to him, if you need this, there's a lot that has to happen before you can have this, like, I need this. But if you do use it appropriately, you'll become dependent, but not addicted.
Okay.
Which is different. But most of the patients I see, especially patients who are, who are involved in car accidents or falls, they really don't require these. As long as you're moving things along prudently, right? Like, so I always tell everyone, let's move with a prudent, urgent pace. Okay. Right? Let's do things correctly, but let's make sure that we do it urgently enough so that this doesn't become a chronic problem. And when you do that, you really can mitigate the majority of people ever needing those getting to a point where they need that medication. Okay. And you end up using anti-inflammatories and other things that are non-addictive.
Okay, I was going to say, you probably prescribe at your practice mostly anti-inflammatories, probably do more of the injection side of stuff. Right. Whereas, like, I'm guessing the pills is for people who are chronic at that point, and the injections failed, they don't want to do surgery, or they're not a candidate for surgery, something like that.
There's definitely a spectrum, and there's a bit of an algorithm. So if someone walks in the office and let's say they had a month ago an accident and their neck hurts, their back hurts, and they're having some headaches, the first step isn't, well, here's Percocet. No. And if that's someone's first step, you definitely want to reevaluate if that's the doctor you want to be seeing. The first step is, okay, it's a good history taking and a good physical exam. That's crucial because that really helps you figure out a list of possible diagnoses, which we call differential diagnosis. And 99% of the time, these are inflammatory problems. So we use an anti-inflammatory. And we show them how to use it. It's not like, oh, I hurt, let me take it, because you never really reach anything anti-inflammatory per se. But if we show them how to take it on a regular scheduled basis for how long, and then in conjunction with certain other medications, right? So if you're having numbness and tingling, I may prescribe you in conjunction with that something that helps with that, like gabapentin, and I'll prescribe in such a way where it will help with your sleep and help with some of that numbness and tingling, in conjunction with an anti-inflammatory, in conjunction with something to help protect your stomach from that, and possibly a muscle relaxer. And which of those I choose and which medication in each of those classes depends on the person's medical history, what I see on the exam. And then in conjunction in that, injections, right? So I may say, okay, look, I think these are your problems. Let's inject them. If I think the right C3, 4, C4, 5, C5, 6 facet joints, which are 3 joints, but I think that's the primary pain generator right now, let's put some medicine on there. Okay. And if I do that, and within 20, 30 minutes, you came in at an 8, and now you're at a 2. Well, now we know that's a problem.
Cool. So you mentioned facet injections, multiple levels. Is that typically done? So what I've seen, and I'm curious, I want to pick your brain. I see bilateral. So I see 2 injections at different levels.
Yeah.
Is that I don't want to say standard of care, but is that customary to do both levels, or would you typically see it done on one level?
It really depends.
Okay.
And this is, again, where when politicians get involved, medicine gets screwy. Mm-hmm. In October 2014, CMS, which is the Center of Medicare and Medicaid Services, started putting out specific guidelines for how these injections, which are actually procedures, but we just call them injections, right, will get approved. And they came up with this really screwy law or rule, which is basically you can only do 5 procedures per body region in 12 calendar months. Now, that sounds like, that should work, right? Now, they also came up with this other screwy rule that says if it's something like a facet joint, you have to do a second procedure to confirm your results of the first.
Okay, to make sure it's not a placebo?
More just to make sure that you can reproduce those results.
Okay.
Because a placebo is basically a positive response, but we know that about 30% of your responses will be placebo. That's why with the statistical significance of 50% is important. Okay. So if you're at a 10 and you go down to a 7, I can't really interpret that as a positive response. Okay. If you go from a 10 to a 5 or a 4, statistically, that's significant. And that's what the studies show us. So when they came up with these rules, the way they grouped body regions was kind of screwy. Like the neck and the middle back are one region. Okay. So let's say you have a herniated disc and it's causing problems in your arm. And let's say you have those facet joints. So I go in there and I do this injection in your facet joints. And then I go back for the second one. And then I go and do an epidural.
Now you're talking about different visits.
Right.
So on one visit you do the neck facet injections, another visit
I do the second neck injection based on the rules. And then the third visit, let's say I want to see if the herniated disc, which is what I would do an epidural for, is causing this problem. So I do an injection there. And then I would have to confirm it again. Now that's already 4 visits. Now, let's say I decide I'm going to do a radiofrequency ablation, a rhizotomy to those joints. That's your 5th visit. That's how I can't do anything else for the next however remainder.
Based on Medicare.
Based on CMS.
Wow.
Now, Medicare bases what it approves and doesn't approve on CMS. And every other insurance bases it on Medicare. So that changed the way doctors started practicing because they realized if you only did one side at a time, that one visit counts as one of those procedures.
Yeah. It's funny. I think a lot of the insurance companies and maybe even CMS, they want to prevent people from getting care that they need by making it so difficult.
Yep.
Who's got time to go every single month, every 2 to 3 weeks to go back? So they make you try it out. There's a guy here in Broward County who he does a lot of health insurance, and he goes, Blue Cross Blue Shield patient, I'm going to have to do 6 weeks of physical therapy. Right. Then they're going to have to do an epidural. Then they're going to have to go back for 6 weeks of physical therapy, get a second epidural. Like he knows. And then Cigna, it's 3 weeks of physical therapy. They have these different rules that are bizarre.
And here's the thing. It's not any of it is not evidence-based.
It's business-based.
It's business-based, and they'll find certain studies out there that basically backs up their opinion. I mean, if we can really dive into this, because what most people don't understand is what drives insurances isn't necessarily them not paying, because they know eventually they'll have to pay. It's something called the float. And they really care about how much money is coming in and how much money is coming out, because they have that all invested within investments that have nothing to do with medicine, and they want a certain return on that. And I was baffled when I heard about this. I was in front of a subcommittee testifying in front of the state of Michigan. They had a subcommittee on health policy, and I was testifying. And there are some guys representing some local insurances, and they just kept on and on about this stuff. And when I started researching, I'm like, this is how they're making medical decisions, right? Just based upon their return on investment, and whether you get that MRI or not. Yeah, and it's crazy. I mean, I can tell you some horrible stories about people being denied MRIs and they died because of it. Wow. Yeah, young guys. So
we got a great cash. That's a great opportunity. We got a great cash price at Tesla MRI. No, it's sad though. I know in Canada borders Michigan right there.
I used to have a lot of Canadians that come and see me.
They come down and they're willing to pay. I had a client here. He was in an accident here. He lived in Canada. He went back to Canada. He needed a brain MRI. And
6 months.
It was a year.
Wow.
Then they told him, I said, look, just come down. I have a place in Boca, 3T. He came down. Not only did he get the brain, he got a special diffusion tensor imaging.
Perfect.
For a brain injury.
Yeah.
Goes back to Canada, goes to his doctor. He said, great. You have a positive finding. I knew you had a brain injury, but this confirms it. So we'll put you in queue to get in with the best brain center in the world. 1 year wait to get in there. And I said, what is this man supposed to do? He can't remember what he did the day before, and he's got to wait a whole year, which I would imagine you want to get in early on, right?
Especially with brain injury.
Yeah.
You got to strike when the iron is hot, and that's what they'll say. Before the dust settles, you got to do it. The amount of Canadians that I had come see me from Vancouver, Windsor, from Winnipeg, I mean, you name it. And, you know, they pay cash. It's like we can't bill their insurance.
Right.
And was crazy. And, you know, this is supposedly world health class medicine. And they said, no, I can't get this care I need because of these wait lists, or it was just simply denied. And what are you going to do? Appeal it's like appealing Medicare.
Yeah.
Good luck.
Right.
Good luck appealing Medicare.
Right.
You're not going to get it. So, you know, to go to your question, whether you do, sorry, we're long-winded.
We're getting there though. We're getting there. This is good.
Rather than doing, you know, is it standard care to do one side or both sides? Unfortunately, after 2014, it became more of a decision of how to practice to make sure that this was covered for the patient. So it became a lot more acceptable to do both sides.
Okay.
Before then, most people would do one side, come back another couple of weeks, and then you did the other side.
Okay.
Because now you can be far more specific in the testing. But since 2014, we did notice some positive responses. Is if you did both sides, you could just end up treating both sides simultaneously. And so it did save the patient some time. So there was some positive benefit from it. Like I adapted my practice, and I now check both sides at the same time if I feel both sides are needed.
Okay.
You know, and that, again, that's where that whole history taking and that whole physical exam comes in. It's crucial.
Be honest. Did Justin Trudeau, was he a patient of yours, or did he get VIP access in Canada, you think? I
think he got VIP access in Canada. Never came to me. No. Never asking for any Percocets. No.
So facet injections, I wanted to ask you a lot, because I think a lot, you know, I'm a lawyer. I didn't go to medical school. I'm picking it up, talking to guys like you who are smart, who can tell me what's going on. And then I talk to the guy who's like a dummy, and he tells me, oh yeah, I just start sticking people with needles, you know, and I'm like, oh my God, don't treat my clients. But there's two main types of pain, right? There's facet related pain, there's disc related pain, facet joint injections, epidural. Sometimes there's both. So you might do facet injections, patient has a good outcome, and then they still have the radiculopathy, pain going down their arms or whatever, so you'll give them an epidural. How often are you finding that the case where there's really two types of injuries, facet injury and a disc injury? Because I know, you know, obviously, you know, from an MRI standpoint, you might have a really nasty looking disc. Nothing comes from it though. Right. And then you could have an okay looking disc that the guy's just screaming in pain all the time.
Absolutely.
So how do you, I guess my real question is, how do you find the pain source of a facet or an epidural?
Sure. So, you know, the way you broke it down, talking about facets and disc, and those are two major classes. You know, about 93% of people who suffer an acceleration deceleration. So if you think about this acceleration deceleration type of whipping motion, they'll have facets in
where their head's rolling forward and backwards after an accident.
You know, and that's gonna, and especially if you're sitting down, your hips are fixed. So your entire spine is now just fixed at the bottom and has this big whipping motion. Causes all sorts of microscopic shearing and tearing of the capsules on these joints. So you find about 93% of these people have facet syndrome, or have some sort of pain generating from their facets. You hit it right in the nail. You see often these discs that are just, you know, if you're just going to go purely based on an MRI, you would just operate on it. But they may not have many symptoms from it. And what symptoms they have may be minimal. Or other times you find near almost normal MRIs, but the person has excruciating radicular pain. And then there's other syndromes in between, but those are the two major ones.
Could you just list
Sure. So, you know, just looking at the spine, right, and not looking at the compensatory pain complaints which occur secondary to the spine, like headaches.
Okay.
But in the middle, we have these ligaments, interspinous ligaments, and they can be very painful. You can have ligamentous structures that attach to the spine, especially in the lower back. And sometimes they'll tell you it's like, oh, right over my hip. Sacroiliac joint dysfunctions, very common, very, very common. We find osteogenic pain or vertebrogenic pain, which is actual bone pain from the vertebral body, which is the front part of the spine. And you look at an MRI and you see there's bone bruising. I mean, there's swelling in the bone, and we can treat that. And that's just a few examples, right? So, and then compensatory is basically subsequent to what happens to the spine, shoulder pains. Right. You can have rib pains. You can have hip pain, testicular pain. You can have even hip dysfunctions.
You got to tell me. One day I woke up. I was freaked out. I thought I had testicular torsion. I'm on Google. I'm like, what is this? What's going on? I didn't have a wild night. I went to bed. I don't know what happened.
If you can Google it, it's not testicular torsion, because at that point you can't even see straight.
Really? Okay.
It's an emergency. They got to amputate.
No.
They got to remove the testicle. Like,
oh my God, no.
I mean, if you let it get bad enough, but it's an emergency. It's a true urological emergency. Yeah. No.
I went to the urologist. He said it was like whatever. I said, fine.
Yeah, epididymitis or something like that. Yeah. You sure you didn't have a wild night that night?
It was. I wish, man. I went to bed. I woke up. I don't know. All I do is work these days. I don't know what goes on. You're the same way. You just left the OR and came here.
Yeah, actually,
this guy came in with the cap, the scrubs cap on.
I didn't. How sad is that? I didn't even realize I still had it on. No wonder that lady driving next to me was looking at me weird. Yeah, she's like, "What the hell?"
But awesome. So to get back here, you think 93% of the patients that you see after a car accident are facet related injuries, or facet and
so don't think of it like one or the other.
Okay.
Think of it like a spectrum.
Okay.
Either you have black and white, right? And then there's a spectrum in between. So, and you have multiple spectrums. So if you look at, let's say black is 100%, white is 0. Well, you're very close to the black of how many of these people have facet syndrome. And then you look at discs, right? And how many of them have discs injuries. Now, here's the other thing. Just because there's not symptoms being produced doesn't mean there's not a problem.
Okay.
Right. And what do I mean by that? Let's say you take a chain linked, right? A linked chain, and you damage one of the links, right? And maybe you can still tug on it and it can pull, but it can't pull, it can't haul. It doesn't have the same tension force as it did before, because one of the links is damaged, and it's more likely to break sooner. Right. So when you have, your disc has to have a certain anatomy. And when that disc now becomes injured, whether it's immediately producing pain symptoms or not, that does weaken that structure. And that sets the person up for other problems in the future. Like all of a sudden, maybe the joints above and below and the discs above and below have to take on more of the workload. Well, that wears them out sooner. Right.
They become thinner.
They can become thinner. They can become drier. They can rip, like imagine a paper cut, right, called an annular tear, which are incredibly painful.
Okay.
In fact, to the point of what we were talking about, like kind of normal MRIs, and they're like, "Oh, but wait a minute, doctor, there's not this bulging disc, there's not a hernia disc, and you're saying there's a radicular component." Yeah, because that paper cut is leaking very inflammatory materials around that nerve.
The fluid inside the disc is inflammatory.
It's extremely. In fact, when that fluid inside the disc, called the annulus pulposus, gets into the bone above and below, that's when you see a lot of the bone bruising. And it's very inflammatory, extremely painful, where we actually have to go into the bone, and there's a particular nerve inside the bone that I sever, I burn. Okay. So a large number of people have these joints that are traumatized. Okay. And I always explain to all my patients, if you've ever eaten a chicken wing.
The facet joints in the spine you're talking about. Okay.
And if you've ever eaten a chicken wing, you see there's a lot of tissue that holds these two bones together. That's a capsule. Right? And if you take that capsule and you overstretch it but don't break it, it doesn't come back to its normal size. And the human body tries to fix that by scarring it down. Now, scar isn't the tissue it replaced. Scar is completely different. And so the scar isn't nearly as elastic, it's not as pliable, and it's not as strong, and it's restrictive in motion, and it can be inflammatory. And so all of a sudden, these joints that were injured have this microscopic, if you want to think of it, paper cuts, and all this microscopic scarring. Well, guess what? That's permanent.
So are these paper cuts the annular tear?
Yep.
Is that indicative of a trauma? If you see that on an MRI, you could say it was a recent trauma?
I can tell you that it was trauma. Typically, if the patient's having symptoms,
like radiculopathy.
Correct.
What are some symptoms? Shooting pains is radiculopathy for people.
Exactly. So numbness, tingling, burning down either the arm or the leg. Sometimes they can have pain just like, and it mimics. So facet joints typically have pain just in the spine. They don't typically refer anywhere. But sometimes they can mimic facet joints. So you do the injections and there's no real response, and all of a sudden, you ask for like a 3 telcel MRI, and there they can see those, a lot of times, those annular tears, and you're like, oh, there it is. And then you do a very specific type of epidural, transforaminal epidural, which just puts medicine right there. And they're like, oh, doc, I feel 100% better. My pain is gone. I don't feel the pressure. But those paper cuts in the disc are indicative of trauma. Now, is it 100% of the time trauma? No, but a large portion of the time. So as you start talking to the patient and they're like, yeah, my neck hurts. Okay. Where? Oh, it hurts over here. Okay. What else? Are you having any headaches with it? Is it going down your arm? Is it going into your chest? Is it going into your jaw? And you start kind of splitting hairs for the purpose of understanding what are all the different things that are involved. And as you do that, you start being able to formulate in your mind, what are the probable causes, what are the probable pathologies associated with this?
Okay.
And then I go off and start testing them. And that's where the injection comes in for the facet joints. That's where an epidural, and what type of epidural, there's multiple different types and different levels and other things. And by doing that, kind of like a process of elimination, if your main complaint is, let's say, your neck, and I put medicine in those joints, and all of a sudden that resolves the majority of your neck pain, then that's what's happening. But if I do that, your neck pain is gone, but now your arm is bothering you. Well, maybe that C5-6 herniated disc that you weren't complaining to me about before, you've unmasked that. Now you're experiencing it. Oh, okay, now let me go and do that epidural specifically at that level. And maybe I do that, and all of a sudden you're like, yeah, my shoulder's really bothering me now. Well, you had a rotator cuff tear that hadn't come to the surface yet, the symptoms, because you were so distracted by this other pain. And you start kind of going down that chain. And that's how it's done. But really, it starts with a really thorough history. I mean, I spend, when a new patient comes to my office, we spend about an hour face-to-face time. Myself, my assistants, just getting all the information from them and examining them. I always joke with them. I'm like, sorry, I tortured you, but I gotta figure out what's going on. Yeah, I tell them, like, when you take your car to a mechanic, they gotta rev the engine. I gotta do the same. And at that point, then I start going down one by one. I do something, I reevaluate. I do something, I reevaluate. And that way, there's no confounding variables, right? If I did this one thing and I see you back in 2 weeks, and you tell me I'm so much better from this, but now I'm experiencing that, great. It's like a science experiment. Okay, now I know these are the results from this. Okay. Let's move on to the next one.
Okay, cool. So, some of the symptoms that we talked about, facet pain would that be a limited range of motion?
It can, absolutely.
That could be disc related as well?
Yes. So, but when people say my back locks up, more often than not, those are the facet joints. Okay.
Because the facets allow you to kind of rotate your back all over.
Yeah, they guide your motion. I mean, if you look at, I always explain to people, if you ever went to the carnival or fair and they had the little wooden snakes that, kids would play and they're kind of flimsy all over the place, that's exactly how our backs are articulated. And that's what allows us that movement. And so when they lock up, basically that joint's swollen. Like if you've ever had a sprained ankle, you can't move it. It hurts. You got fluid. It's very painful. Same thing with these joints. Okay. And then definitely shooting pain, that's more disc related. Well, the problem in medicine is you can't always say 100%, right? If you could, my job would be so much easier. So very often, right? Okay. Very often being like 80% of the time, when someone's complaining about shooting pain, you're definitely thinking about disc. Okay. Now, facet joints can cause radiating pain. The difference is if anyone ever feels nerdy enough to do this, you can Google human dermatome map. And it's a map of where the nerves that come out of the spinal cord give sensation to different parts of the body. And so when someone says, it goes down my whole leg, And we start asking them, well, does it go in the front of the thigh, back of the thigh, the outside of the thigh? And your calf, well, is it on the left side of the calf, or the inside of the calf, the outside of the calf? Does it go to your ankle? Which side of the ankle? What part of the ankle? Where in your foot? Bottom of the foot, top of the foot? That's because in my mind, I'm going through that dermatome map.
Wow.
And so all of a sudden I can say, is this an L3, right-sided radiculopathy versus an L5 or whatever? Facet joints will cause pain to go down the extremity, but it won't follow that map. So they'll say, yeah, doc, it just catches part of my thigh here and kind of like inside and outside of the thigh. And it's non-dermatomal. That's what we mean. Mm-hmm. So yeah, it goes down. Like the example I used, it can go into your testicles, right? I've had males that say, yeah, man, my balls hurt.
Yeah.
You know, when my back is hurting, my balls are killing me.
Yeah.
And Lord and hold, you know, I do the facet joint injection. They're like, doc, I feel like someone stopped squeezing my balls. Yeah. And
I'll tell you a funny story about that, but go ahead.
No, tell me. So
I had a client, Dominican guy, and I guess he had high blood pressure issues, maybe diabetes, and he had an injection, and I guess the steroid can affect the male. What's a nice way of saying
performance?
Performance. He was not performing.
Yeah.
And he had a 10 out of 10. I don't rate women, but she was a 10 out of 10 Dominican chick.
Wow.
Who was
Tigresa.
Yes.
Tigresa.
Que lo que. And she was very upset about his lack of performance, and even worse, the guy's in pain. He's in a car accident. He's in pain. He had to get this injection. Now she's accusing him of cheating because, well, if you can't perform for me, you must be performing with someone else. And so he brought her into the office to meet me so that I could explain as the lawyer. I talked to the doctor and blah, 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 whatever, and got all this information verified, you know, and I had to tell her, I said, listen, you should be thankful that he's even like, you know, around. This guy's in pain and this can happen. And I had to explain it to her. She was really upset.
Wow. You know what's crazy to me? How often people initially will go to their lawyers for medical advice.
Oh my God. I'm practically a doctor with some of these people.
I mean, how many times I'll tell you something that's interesting about medicine is, you know, if you look at how many years it takes to create someone like me, it's about 15 and a half years after high school. And this is more than full time. Like you're talking about, you spend 80 to 90 hours a week doing this week after week after week after week. And as you get up higher in those years, the time commitment only increases. So that's equivalent to 2 PhDs, right? So you have this fund of knowledge and practice, and now you're going to take it and apply it and offer it to people who really don't have an understanding, even a fundamental understanding of this. And I think the art of medicine is being able to communicate effectively what the hell you're saying. Like, can someone understand it? You know, that's why, like in the office, you know, we avoid the words dermatome or like medical words. And we have models. Like if I explain to one, look, this is what a facet joint is. It's a joint like your knee or an ankle. And if you ever sprained your ankle, you know, it swells up and it hurts. Well, that's what happened here. But unfortunately, a lot of times it's, you're right. You know, doctors are just so in this mode, and they're not doing it to show off. They're not doing it to be a dick or anything. They're just, you know, you think about almost, you know, 16 years of just doing this 100 hours a week. You know, your brain really starts thinking like that and it starts communicating like that. And you forget that not everyone knows what the hell you're saying.
Yeah. I think just people in general, especially a lot of the clients that I deal with, they're Hispanic origin. A lot of them don't speak English, and so you speak Spanish fluently. Yeah, cool. So one, there's a disconnect between the doctor who doesn't speak the language, and then two, there's the intimidation. The doctor, the level of respect that people have for the doctor. Some people, you know, there's some wackos in your office every now and then, but most people have a high level of respect. When you say, oh, I'm a doctor, they're like, let me open the door for you. Let me help you out. You know, they feel like it's just a natural instinct.
Especially in our culture, right? You know, in Hispanic culture, it's so, I mean, I don't want to say casted, right? But professionals definitely have a different standard or held in a different way than, let's say, non-professionals. Hispanic culture.
They all want to call me doctor because in South America, Caribbean, the lawyers are considered doctors. And so they call me, doctor and all that. But so let's get back to the injections. I want to ask you about it. So there's two types of medicine that you'll typically do. Correct me if I'm wrong. You have the numbing agent,
which to numb your skin.
Okay.
And then afterwards, in whatever I'm injecting, that's actually the most important part, the numbing part, because that's where the test comes from.
Okay.
Right. If I don't numb that and I just put an anti-inflammatory, well, that doesn't kick in sometimes for 3 or 5 days.
Really?
So steroids don't kick in until 3 or 5 days. So if I'm in that joint, facet joint, SI joint, a knee joint, whatever, and if I don't put that numbing, then I don't know how you're going to feel in 20 minutes. Like that's actually the most important part, that numbing agent.
And the numbing agent lasts about, and this part's, I guess, more for like patients.
Sure. So 2 to 4 hours, sometimes 6 hours.
Okay. And that's Marcaine, lidocaine.
Yep. So most people know those as xylocaine, right? When they go to the doctor.
Okay.
To the dentist, and they're like, "Oh, can I get xylocaine?" It's lidocaine. It's just a brand name to it.
Okay.
Marcaine is a different form of numbing medicine, all in the same family. Lidocaine doesn't last that long, maybe 2-3 hours. Marcaine tends to last up to about 6 hours. So you use a combination to give the patient a little relief as well.
Okay. Because people will say, "Oh man, I'm cured now." After that, right? Is that what that is?
Yep.
They're like, "It's fine. It's gone."
Right. And also, it's now that you said that,
then it wears off.
Right. Yeah. And that part of that's really important too. Also, expectation management. Telling the patient, this is just a test. You have a 50% chance of the pain coming back within 2 weeks, and you have a 50% chance of it not coming back after 2 weeks. But it's just a test.
Okay. It's just a test. And so you'll do the injection with the numbing agent. You'll hit them with the steroid. So I didn't know that.
Sometimes.
Sometimes.
Yeah. So there's different type of anti-inflammatories. Steroids, what people call cortisone.
Okay.
Which no one uses cortisone anymore, by the way. Everyone says la cortisona, the cortisone. No. It's some sort of corticosteroid. Whether it's Kenalog, which is known as triamcinolone, or Solumedrol, or betamethasone. Those are all steroids.
They're all okay.
So you can do that. You can use...
Those are brand names? Chemical compounds?
Those are the chemical compounds.
Okay.
Kenalog is the brand name. Triamcinolone, it's its generic name.
Okay.
Or you can use actually something like Toradol or Ketorolac.
Okay.
Which is, if you ever gone to the ER and urgent care, you're in a lot of pain, they'll give you this little shot in the butt of this medicine that about 30 minutes later, you're like, oh, I feel better. And that's what it is.
Okay. That's an anti-inflammatory as well?
Okay. And then a lot of my colleagues have found a substance named Traumeel, which, believe it or not, it's homeopathic. And so...
Define homeopathic. What do you call that?
So homeopathic medicine is a whole different realm of medicine. And so they have this philosophy about the essence of molecules and what have you and substances. So it's a very different field. The way they gauge medications is by how often it's been diluted. And so it's like a natural form of medicine, if you will. Okay. So it's very different.
Is it considered an anti-inflammatory as well or no?
Well, the studies have shown that it works very well, comparable to like the Toradol that I talked about. And some studies I've even seen are comparable to like the steroids. So if you have a diabetic patient, right, you don't want to give them steroid.
Okay.
You can put them in a diabetic coma possibly if you shoot their sugars up to 600, 700. Let's say they have heart problems or kidney problems. Well, you don't want to use the NSAID, the Ketorolac, right? Because that can cause heart and sometimes kidney problems in people who have those issues. So we're left. Well, now you have this homeopathic option. And so, just making sure you have this breadth of anti-inflammatory options for the right patient. The strongest medication is the cortisone, the corticosteroids. That you have the best long-term. And when I say long-term, I mean like a few months.
Oh, wow.
Relief.
Okay.
Yeah, sometimes longer, maybe a year. But unfortunately, what happens is people, like you said, they think they're cured, and they're not. You just really calm down that inflammatory response. Okay.
And so the goal with any pain management is to reduce or eliminate pain.
Ultimately.
And so... some people don't understand that they may have pain the rest of their life. Unfortunately, after an accident, they may have severe pain for the rest of their life. I guess, the injections are temporary. How many times could somebody get an epidural? Sure. A year, a lifetime, stuff like that?
Yeah. So to answer that question directly, it depends on how much steroid exposure you've had. Right, and which steroid. So if you're using something like Kenalog, they'll say, well, about 180 milligrams of that within a 90-day period. So effectively, you could get 3 injections, like 3 epidurals, about every 6 months.
Okay. Right? Is there any kind of degenerative issues that people have from that?
So if you have too much steroid, and again, it's the medication, it's not the procedure, it's the medicine used. So from the medication used, the steroid itself, if you expose someone too much to it, multiple things can happen besides the whole sugar thing. One, you can have actually softening of the bones, bone loss, osteopenia, osteoporosis. You can also have an adrenal gland failure, which leads to a condition called Cushing's syndrome, which is where people swell up. They have moon face because literally their face gets like a moon, and they develop a hump in the back of their neck called the buffalo hump. And it's problematic. You can have after a while, it can actually have the opposite effect. It can actually lead to changes in the actual shape of the bone, of the joint, osteoarthritis. But that's not going to happen after 1, 2, or even 3. I mean, this is continued exposure. And to the point, the ultimate goal of pain management is to help reduce or eliminate your pain. The first goal is to help diagnose what's the causes of it.
Okay.
Because you can't fix your car if you don't know what's wrong with it. And maybe sometimes if you can't fix it, but you can rebuild it. Like, maybe you can't change the transmission, but you can rebuild it. Okay, well, now the parameters. Right. Well, if I don't redline the car and I don't decide to take it out for a drag, the car works fine. So the first goal of pain management is really to help diagnose the causes of the problem. Once you do that, then you deal with each cause individually. You can be very precise and very concise in how you do that, very strategic. And now as you're doing that, you're giving the patient management options and strategies on how to control this stuff. And, you layer it. Like, you don't just say, hey, I'm going to jump and do a discectomy on you. No, you want to stage it from conservative to most aggressive in terms of management. You don't just start off with giving someone OxyContin, right? No, let's try an anti-inflammatory way before any of that. So as you do that, you start developing strategies for the patient. At the end, this patient, despite all this, is still, like you said, let's say in severe pain. Then we have other options, like what I did today, a spinal cord stimulator, permanent implantation.
That's what I was getting at, baby.
Yeah. So, or other more invasive things, right? Like there's a procedure called an intercept where I go actually into the spine, into the bone of the spine, the vertebral body, which is the front of the spine. And there's a nerve there that goes and kind of gives sensation to the bone. And I burn that nerve versus...
How's that different from a rhizotomy? Because you said burn the nerve, and that's typically the language that I am told is...
So I wish I would have brought a model. This would have been so much easier, the spine model. So if you think of a joint, right, and the joint looks like this, and there's a little nerve that goes to the joint. Okay. So in a rhizotomy, I wonder if I have a pen. So I lay this cannula, looks like a straw, looks like or a needle, on it.
It's like a little tube that you work
exactly.
in. Exactly.
I lay it right on that nerve, and I essentially burn it. Right. Now, there's some, and I say burn with tongue in cheek because I'm not really charring you. Okay. But I definitely, there's heat applied there, and it does create a lesion.
Electricity?
It uses a form of electricity to create very intense radio waves. Okay. And so, I don't want to bore you guys with too much technical information here, but if through that straw, through that needle, I place a little wire in there. That's an antenna. Okay. And then that antenna pumps out this little radio wave. That's why we call it radio frequency.
Okay.
Which is also known as a rhizotomy, right? Okay. So the radio frequency, I control the frequency of the impulses of the radio waves. Now, in the middle of heating, I can pull the thing out and touch it. It's not even hot. It's just an antenna. It's no different than an antenna.
Wow.
But the tissue around it who's receiving that radio wave is heating up.
Wow.
Now, I can control the temperature. I can control the length of the burn. I can control voltage, amps, resistance, which is ohms, on the machine to produce different things. I can put the needles or the cannulas in certain patterns to create different shapes of the burn, because I can get very specific in the shapes. But for that joint. Now, in this other procedure, Intercept, if you think of a box, okay, and imagine in the middle of the box this nerve going into it. And then it divides and shoots some little nerves up to the top of the box and then to the bottom of the box. Okay. Now, the inflammation in the bone is both in the top and the bottom. It's actually in the bone. It's like a bone bruise. It's swollen. Okay. So in the spine, here's your spinal cord. Here's this box, the vertebral body. And then there's a bone that connects the box to the back of your spine. And then it creates a canal in the middle. Okay. I go through that bone that connects the back of your spine to the front of your spine called the pedicle. I go through it all the way into the vertebral body. And I find that nerve. And then at that point, I use also radio frequency. Okay. But I sever that nerve. That one I want to burn. Okay. That one, actually, you can see the burn on MRI. Oh, wow. And it looks like a target. It looks round with a little dot on it. And you can see it. In fact, you always have to let the radiologist know if they get an MRI afterwards, because if not, they think it's a cancerous lesion. Oh, okay. Because you're burning. Yeah. You're burning that. Wow. You're still using radio frequency technology, but applied very different. Like, I can do that to the occipital nerve for headaches. Right. Okay. I can do it there's a nerve in the shoulder that can cause people, let's say they've had a shoulder replacement and they're still hurting. Or let's say they've had a whole knee replacement and they're still hurting. I can apply radio frequency technology in very controlled ways to help mitigate that.
I've never had an RFA explained to me so beautifully. Oh, good. Okay. And cool. Awesome. And cool. That was, I don't know this stuff. This is really cool. And I think the viewers would appreciate it.
Yeah, I really wish I would have brought a model. I mean, this is, I obviously I get geeked out about this. I can talk about this stuff all day.
It's cool.
This is, I tell people where we are with medicine, this is like Star Trek stuff. Like, if you would have seen what I did today, this is Star Trek stuff. Like the spinal cord stimulator.
You're a Trekkie, not a Star Wars guy?
I'm both. Yeah. I'm both.
Who isn't?
Exactly. Live long and prosper. So where we've gone with pain management is actually interventionalism. And interventionalism is essentially minimally invasive surgical procedures to help diagnose and treat the problem. Okay. So like when I said earlier, we call them injections, but these are really procedures. I'll give you an example. I had a patient, this is a few months ago, who their airbag went off, hit their face really hard, jaw dislocation. Okay.
Literally dislocated
to the side. Wow. Like the jaw was this way. Oral maxillary facial surgeon, reattached the jaw, did everything. Okay. But then they developed something called trigeminal neuralgia, which is a very specific type of headache. It is, again, I've known doctors who have had patients commit suicide over that type of headache. It's as if someone's taken a knife and a hot poker at the same time, and just in the most deepest recesses of your head, behind your eye, just burning. It's horrible. And this patient had that, and their whole face would droop. Their eye, they felt like there was sand blasting in their eye. This horrible skin burning, like a horrible sunburn on their face. Their teeth it was horrible. They couldn't eat. I mean, the person had lost like 30 pounds. And so that nerve,
miserable, by the way, when they see you.
Oh, I mean, they this person had their wife left them. Wow. And they had lost their job. And they had no more income. They were about to get kicked out of their apartment. Like, this person's life, I mean, they lost everything. Wow. And I wish, people understood that. Like, this isn't like, hey, wink, wink, I want some money out of this. Like, these people are messed up. Yeah. They come in crying. So what did I do? I talked to him. I had a very high suspicion this is trigeminal neuralgia. And so I took a cannula, a special spinal needle about 5 inches long. And going from here, I went right into the base of the skull where it houses the brain. There's a hole there. And that's where the nerve comes out of. And so essentially I'm right in that hole and the brain is sitting up top here. And I put contrast and you can see the whole brain bulge. Like, I'm basically there.
You did this under, like with the C-arm or what?
Oh, absolutely. Everything I do is under the C-arm. And C-arm is a special type of live x-ray. So I can see everything because, there's a lot of arteries. There's a lot of stuff there. I did that. And the person's fully awake, by the way. And I'm talking to them and talking them through it. And I used radio frequency to treat that nerve. And Lord and behold, I saw him back a couple of weeks ago. Hasn't had one since.
Wow. That's crazy.
He's like, he couldn't thank me enough. He brought me a big ham. I'm like, yeah, you don't have to.
Wow.
But my point in telling that story is traditionally the way you would treat that is you'd have to open up the skull, expose that nerve. So basically you're looking at the brain, you're looking at that nerve, and you have to dissect down there, separate the artery off that nerve. There's some consequences to having your head cracked open.
Yeah.
And so I was able to do it in the span of 30 minutes in an office.
Yeah. There's not a lot of guys, and I don't mean to pump you up, but there's not a lot of guys. Brad's going to kill me. I don't think there's a lot of guys that could do what you did. I think there's a lot of doctors, their pain management. They're like, they do epidurals, they do facets, they do rhizotomies, refer them to surgery.
Yeah. And unfortunately, if they understood that that's someone's family, right? They wouldn't be so process oriented about it. My parents are sick. That's why I left Michigan. They both have lung cancer. Oh, wow. That's why I came down. Wow. And I had to go, I took a sabbatical and I was going to them with all the doctor's offices and their appointments, and I would see that. It was very like cookbookish. Yeah. And I would say, if this was their mother, is that what they would do?
Right.
Yeah. I doubt it. And I think a lot of these guys that you described who are doing that don't stop to ask that question. Right. And so, and if that's the case, then I don't really understand why they're practicing medicine in the first case. I
think that's a more complicated procedure, what you're talking about there,
it is.
Now, I think you got to be good.
You hit it on the nail. You have to have the right training, the right understanding. Luckily, and this is in Flint, which I'm very grateful for there, I saw everything. These people would get so injured. And there was no one else around to take care of them. So it was me and my partners, and that was it. And I was the young guy. And so they just got fed to me. And I got to see it all. And so I really developed a really holistic approach from head to toe, and I started having urologists send me tons of patients, women who had interstitial cystitis and, this horrible stuff. And so it's nothing to do with, actually, interesting enough, I did have a girl who she was in the back of a truck loaded with PVC pipes. And you can see where that's going. And they were rear-ended. She fell, and one of those PVC pipes penetrated her.
Wow.
Yeah. And, horrible pain. Gynecology did everything they could and what have you. And they sent her to me to see what I could do. Wow. But I got to see it all, and I had to help these people. Like, no difference. If this was my parent, do I want a doctor looking at them and saying, sorry, there's nothing more I can do for you. You got to live with it. Right. I don't want someone to say that to my parents. And so that's how I practice. And so you get smarter when you challenge yourself. And you're honest to patients. I mean, I would tell patients, look, I don't know, but we'll figure this out. They appreciated that honesty. And I would do that. Now, there's definitely times for clear surgery. I mean, there are times that patients come to me now, and I'm looking at them like, look, this is not something that you should be meddling with interventional medicine. This is surgical. In fact, it's surgical now. And being a part of a multidisciplinary group, which is great, I just called up like Dr. Puccio. I'm like, hey, I need you to see this patient now. This is someone that you should be doing surgery tomorrow.
What can you give me some examples of that?
Yeah. So actually, that's a great question because I've seen this multiple times. And cauda equina. So let's say you have a really huge disc, right? That's pinching the spinal cord acutely. Okay, so this disc pops out and pinches the spinal cord. So the spinal cord is what connects your brain to your body. And a lot of times it happens, towards the bottom half of the spinal cord. And when that happens, all of a sudden, you can have urinary changes, like all of a sudden incontinence. And incontinence isn't like, oh, I can't hold it. No. Like, oh, shit, I'm peeing. Like you see it on your pants.
Wow.
Or you're just pooping, right? And you have anesthesia, like it's numb between your legs. And you start having gait problems. And if you're a male, like impotence, right? Erectile dysfunction, which is why guys come to me with back pain. I'm asking them about erectile dysfunction. And they're like, wait a minute, are you a urologist? No, that's a neurological problem.
Right.
And so I've had patients come in. They have weakness in their legs, and they have these bowel bladder changes, and we call it saddle anesthesia, so it's numbness between the legs, and that's a neurosurgical emergency. Like you need surgery.
What happens if they don't treat it
paralysis?
Right away? Oh wow. Temporary, permanent, either?
Oh no, it can be permanent.
Wow.
It can be permanent, and so you need to reverse it as soon as possible. Nerves are extremely sensitive, so if you keep irritating a nerve or pinching a nerve, it'll simply die. I mean, if you want to think of it that way. And so, in your spinal cord is how your brain controls your body, right? And so if you don't take care of that, that's an emergency. And it's not like you can wait on this. Pills ain't going to fix that. An injection isn't going to fix that.
Right.
And I've had a few patients walk in with that.
Wow.
Other things. So I've had multiple patients who were in wheelchairs talking about people who are paraplegics and get into accidents. And people are like, well, you're paralyzed. I mean, you can't feel anything. Oh, no. There's problems. I've had, in fact, recently a gentleman who's himself an attorney, and he's an attorney outside in one of the Caribbean countries, in Trinidad. And he comes and sees me because he was here and he had a bad accident. And so he's been paralyzed from something years prior.
Okay.
But he was concerned. He's very well educated, and he just wanted to make sure he was okay. And as I started asking him about his blood pressure, and he's like, "Yeah, I have noticed that my blood pressure has been a little higher. I've noticed that I'm kind of sweating more, in the areas I'm not paralyzed, and I've noticed that my hair is standing up more." That's an emergency, autonomic dysreflexia. That can cause him a heart attack or a stroke.
Wow! And
because there was an injury in his back. He had suffered a fracture, and no one bothered taking a look because he's paralyzed. He's a complete paraplegic. And so no one bothered doing an MRI. And so I got a CAT scan because that was the quickest thing. And I saw it, and I said, you need this repaired. And I explained to him that is causing this drive of this problem. And if we just leave it there, he can actually stroke out or have a heart attack or something like that.
Wow.
So we repaired this fracture in the area that he was numb.
Was that like a kyphoplasty or what?
I did do a kyphoplasty on it.
Cement in the spine.
Cement to the spine, but not Home Depot.
Not the Home Depot stuff. I'm sure it's a lot more expensive than regular cement. I think this has been really informative. I feel like I've learned a lot. I hope the viewers learned a lot. Anything you want to add?
The big thing about it is the take-home message is, it's more than just pills or more than just an injection. It's really a branch of medicine that their first focus should be establish the diagnosis, figure out all the different things. That's the key word. Things, not thing.
Not just one.
Right. It's not just, is this problem or this. No. What are the multiple things affecting you, and what are the symptoms associated with those things? And then be specific. Concise and precise is the way to treat it in a very prudent, urgent manner, right? So as to avoid this becoming a chronic problem. And those conversations should be taking place so that patients at least have an understanding. And it's not just, hey, let me get an injection, I feel better and I'm good, or let me get a pill and I feel better. No. Because once all is said and done and all it's been diagnosed, then you can start treatment. And once you have the treatment, the long-term effects of this treatment is basically you're going to have to rehab yourself at one point. Like, you're going to have to be diligent on exercises, staying fit, because that injury is always going to be there. It's permanent. And that's the key thing. But that doesn't mean you have to suffer, right? You'll have things you can easily do to control and to control it. And so you can empower people to help themselves with this long term.
Awesome.
Yeah. So
awesome. And where do you practice? Because you're everywhere. You're like me. You're on the road a lot.
Yeah. So
what locations?
Yeah. So University of Orthopedic Care has over 12 locations throughout the West Coast, East Coast, and Central Florida. I personally go to our Tamarack office, our Hollywood office, Palm Springs, Port St. Lucie, and Orlando. I am the chief medical officer for the whole practice. So sometimes I go out to the West Coast, but more kind of like looking at healthcare policies, making sure that everyone's doing things, when we open up a new office, the flows are well, that our protocols and policies are practicing good medicine. But where I see patients are in those areas.
Okay. Awesome, Doc. Really appreciate it. We'll put your contact info in the video so people can find you. Yeah. Thank you, Doc. Appreciate you.
Thanks
so much.
Appreciate it,
brother. Thank you. Thanks. Cool.